So good. Well, I'm Eric Caine. I'm from Rochester, New York, by way of Korea, Beijing, and Hanoi. And so parts of my brain have been left in each of those areas. And they'll probably coalesce in a few days, but it's really a pleasure to be here. So if I say anything irresponsible, it's not because of my character or my Axis 2 diagnosis. It's just a normal aspect of who I am. I'm going to show you a lot of slides. I will skip over a bunch of them. I made too many. And part of the purpose is, well, there was twofold. Annette initially told me that she didn't know how many speakers there might be, and so I had to be flexible, so the slides are like an accordion. And also, they're going to be available for handout, and so don't worry about trying to take notes on everything. Now, I'm going to say several key things because I am very, very realistic about what we do and what we don't do. My background is as a clinician. I was an inpatient psychiatrist for many years. I ran an outpatient department. I still head a large department of psychiatry. It has 180,000 outpatient visits a year and 12,000 admissions. And as a clinician, I focused on the sickest of the sick, which meant I saw many suicidal people. And I've always asked myself a key question. Do we make a difference in people's lives? I will not accept from myself, oh, they got better and got out of the hospital, as making a difference in someone's life. What I accept is that someone's different a year, 2 years, 5 years from now, that they're alive. And one of the things I'll say at the outset is I don't think our field, and collectively, does enough of that measurement of do we make a difference in people's lives. We're satisfied by what we do today and say, oh, they seem to feel so much better today. I encountered them in some way or other and they're different. That's not suicide prevention. The second thing I would say is that from working in the medical examiner's office, and my colleague Yates Conwell, who's one of these people I've mentored, he's really now about 7.5 feet tall. He started this big. We have a lot of fertilizer, we grow people. We started psychological autopsy studies where we went and worked with a medical examiner, the coroner, you might call them, and looked at these deaths that were coming in by suicide. And at that time, I thought, oh, we just need to get people more psychiatric care, my field. And it turned out that was absolutely wrong. There were many people, elders, they didn't even talk to their primary care physicians about their mental health or emotional problems. The primary care physicians would see them in the last day of life, week of life. 70% saw their primary care physician in the last month of life. And their nature went unrecognized because the people did not want to be recognized. They did what they needed to do what they wanted to do. These were not impulsive events in these elders. And many of the people we saw had touched the mental health system at one point or another, but they weren't inside it at the time. So we weren't there where we needed to be, and they weren't close to us. A third issue. Many of the strategies that we've taken, which on the face of them appear to be good, are not successful. And I will talk about the fundamental reasons about that and challenge myself, as I do, and others to consider those in the context of the United States. I will say nothing about New Zealand because I've just been here a few hours. So it's always good not to talk about what you don't know about. Oh, wait a minute. I guess I better stop talking now. A lot of people argue that we don't know about suicide enough. How can we talk about it? Here's the dilemma. In the United States right now, the suicide rate is about 12 per 100,000 in the general population. That means in the coming year, out of 100,000 people, 12 will die by suicide. Now, if I said the suicide rate in people with major depressive disorder, which we all call a, quote, risk factor, is 500 per 100,000, we would say that's stunningly higher, just astronomically higher. So in the coming year, out of 100,000 people with major depression, 500 will kill themselves. The question, if I were putting 100,000 people in front of you, I would defy you to pick out the 500 major people with major depression from the 99,000 500 people with major depression who weren't going to die. We cannot do that. All of our screening and high-risk approaches fail in study after study to reduce measured suicide rates because we can't tell the very sick, the very distressed, from those people who in their hearts or minds have decided to die. This is something that we have to be sober-minded about, and we have to understand that it requires different approaches. Now, my guidance on how to deal with this is history. So in the United States, when I was coming of mindfulness in my teenage years, yes, my brain wasn't developed and it was impulsive and all those other things, but I still had some thoughts. One of the things that was going on during those years was that the United States was spending in the 1960s gobs of money on building intensive care units in hospitals to get people and prevent their death from heart disease. Turned out 10 years later they hadn't had any impact on the death rate. Why? 3/4 of the people died before they ever got to hospital. And the ones who got to hospital, they maybe lived a little bit better, but they were such a tiny fraction of the potential mortality. Now, in the US, for a period of time, there was actually a lot of good, sensible advice about exercise and weight control and all those other things. And so a generation from my parents who heard this to people somewhat younger than me actually started to do those things and kept healthy. And the death rates in the United States from heart disease dropped dramatically 20 years after they started doing these things. The death rates were affected by things that happened 20 and 30 years before. Now, of course, in the United States, there's a great epidemic of obesity, and we can guarantee that the death rates are going to start going up. And indeed, in some parts of the population, they already have. So this tells us something, that we have to look to suicide prevention programs that are based ultimately on dealing with folks, with people, before they become suicidal. If we wait till they're going to the edge of the cliff, we will largely lose them over the cliff. And I just want to say that over and over again. Doesn't mean that we don't treat distressed people. Of course we do. I run a large clinical department that treats plenty of suicidal, distressed people. I'm treating them not because I'm running a suicide prevention program. I'm treating them because they need treatment. But that's very different than a suicide prevention program. So suicide's the 10th leading cause of death in the United States now. It's had the great honor of moving up from 11th. And it's not because other things have gone down, it's because suicide's gone up in this case. This year, suicide will pass mortality for road traffic accidents, which is an ignominious distinction. Suicide is the 3rd leading cause of death among youth under the age of 19. Homicide Homicide and suicide are this close. Over the age of 24 to 34, actually, suicide is the 2nd leading cause of death. Suicide now accounts for about 37,000 deaths in the United States, homicide for about 17,000. And this trend has continued such that it's certainly basically 2 to 1, but there's no way in which the homicide prevention spending, I mean, if we could have a little fraction of that for suicide prevention, we would be in lots of money. The suicide rate in the United States has essentially remained flat after the Great Depression, but when you really start to look at this curve, what it turns out is in the last decade it's gone up 16%. Now, the dirty little secret of this is that suicide among youth has remained generally flat. Suicide among elders has gone down. The entire rise of suicide in the United States has been from the ages of 35 to 65, 64, and that has gone up 26%. And I will say at this point that that is the area of least spending and least attention in the United States, although it is the area of greatest contribution to mortality. And the reasons go back to some of the things that our first speaker talked about. Policy is not just about science, it's about personal priorities. So in the United States, all, or 99% of the suicide prevention money is spent on people ages 24 and younger. The congressional people who passed this lost children. The family advocates who supported this lost children. There's more money spent on children in schools and in universities. Now, the irony in university is the suicide rate is about 6.5 per 100,000 in that age range. Students of the same age outside of university have double the rate. If you reduced in the United States the suicide rate under the age of 18 and under, by 50%, you would reduce the suicide rate in the United States by 2.6%. So because of our values and our pain and our suffering, we do not always make expenditures based on what you might call optimal public health policy. We make our expenditures based on, in the United States, on how the heart goes as well as how the head goes. Now, we've just had a discussion about the national strategy of suicide prevention, and I've been a pain in the butt, except that's not quite the way I put it, in that discussion, because at the beginning nobody was talking about people in the middle years. But in fact, they've now recognized that. I guess it was more painful to deal with me than to actually, put that into the strategy. But clearly, the bulk of suicide is a target if you are going to have a suicide prevention program. Otherwise, you're only addressing a small piece of a far more complex issue. And I'm going to come back to that middle years for other reasons. So there are a series of challenges, and I'm going to go through them very quickly, and there's more material, as I say. Number one is we can't tell the relatively true cases from the false positives. And I made that point already by saying, none of us would turn away from treatment 100,000 people with major depression. They are really distressed. I'm not talking about, I'm having a bad day. I'm talking about major depressive disorder. Even though only 500 of those, and that's I'm putting that even though with sort of quotes and parentheses and asterisks and everything around it, only 500 people would kill themselves. We treat those people because they need treatment. And I am vigorously supportive of mental health treatment. But I don't view that as a highly effective suicide prevention program, although it's essential for society to treat anybody in need. And there's a very clear-cut reason why the so-called risk factors for suicide are not really the real thing. Risk factors are intended to predict outcomes with greater probability. I took part in studies which were criticized, and I later criticized my own studies, because we did a bunch of people who had suicide versus community controls and said, oh, these are statistically significantly different. Therefore, they must be risk factors. Turns out that's not true. They're differences. But a risk factor is something in a population that has something called positive predictive value or predictive validity. None of the risk factors, so-called risk factors for suicide, have predictive validity. And the reason they don't is they are common. Depression's common. Drinking's common. Family turmoil's common. They cannot predict rare events. A common thing cannot predict rare events. Drinking milk is common. It does not tell us who's going to die of drug overdoses. So this is their clinical features. I'm not going to go into this a lot, but there's a fundamental flaw in our thinking which took me years to really understand. Now, self-inflicted injury, if you see in the United States, is very high among young people. If we said self-inflicted injury was the risk factor for suicide, then most of our suicide would be among young people. But it's not. The suicide rate in the United States under the age of 18 is really quite low. Between 18 and 24 it rises, but as you can see from this figure, the action is right in here. It's men in this age range where the bulk of suicide occurs, and that's even more evident in this slide, which talks about numbers as opposed to rates. Every country should look at the numbers of suicide and the years of potential life lost, and this shows that the action's right here in terms of the real numbers. Now, who are those people? Well, those people turn out to be the parents who create the turmoil in which the young people who later go on to suicide live in. And so if you're going to have a comprehensive prevention program, you actually cannot outrun the family. You can try to work with the youth. You can try to do things in school, but I defy you to think that you can turn over and ignore the effects of the community and the families. And these are the families, both men and women, who have the substance use problems and the family turmoil and the interpersonal violence and all the other things which precede and set in motion the basis for the suicide later on. This is a slide from CDC, and I have a number of slides here from CDC, which just shows that the ratio of suicide to seriously considered suicide is 1 to 200 and something in CDC statistics. So if you used seriously considered suicide as your entry point, you'd have to pick one person out of 200 in order to decide which one's suicidal. Now that's better than 500 out of 100,000, but nonetheless, it shows you that that approach is daunting. We do have what are called indicated interventions. I'm not going to go into that much, and selective interventions for individuals and groups that are at higher risk. And it's really clear that people who have these risk factors, let's call them clinical features, need treatment. So this is not we turn away from them. It's rather that we don't necessarily depend on these programs as our primary mode of reducing suicide. In fact, I think they contribute as part of a mosaic, and I will talk about that shortly in my last few minutes. But it's not the same thing as saying, this is my program. If this is your program, then largely the suicide rates will increase around you and you will have no influence on them. And that's exactly what's happened in the United States, where after the first national strategy, people built all sorts of programs like this and others, and the rates have gone up. And the rates have gone up not because people weren't running good programs, it's that they were paying attention to other groups that were desperate for treatment, but didn't necessarily change the national rates. And I talk about national rates because if you've got to measure something, that seems to me the thing to measure. Challenge 2. If you haven't learned it before, you certainly learn it painfully, which is people who are very suicidal often don't tell you. And you discover it when they're dead. And we saw this over and over and over again, even among psychiatric patients. They will be discharged from hospital, and at the time they're being discharged from hospital, they deny that they're suicidal, and then they go to die within the next few weeks or a few months. The studies in the UK very aptly demonstrated that. So this is where we use means control or means restraint, where you have a sweeping and broad kind of intervention. Think of no smoking policies as broad universal interventions. And means control has its benefits. But you'll see, though, number 2, alcohol and substance use prevention and control, and we'll come back to that. If we had really good alcohol and substance use prevention measures, careful monitoring of the age of drinking, careful monitoring of speed limit, careful monitoring of use in society, we would have far more impact on suicide than probably anything else we could do, as well as accidental death. And I'll show you a diagram at the end, because this is what we would call a common risk, or removing a common risk that's underneath a whole bunch of adverse outcomes. This is from the UK. This is where they took the carbon monoxide out of the coal gas. This is the level of the carbon monoxide coming out of coal gas and changed over to North Sea gas in the 1950s to 1970s. That was the reduction of carbon monoxide. And you can see, again, these slides will be available to you, that the suicide rate came down dramatically with the reduction of carbon monoxide. Now, this was not done by a person. This is the kind of policy that's implemented by government broadly that doesn't depend on a person's action. These are very effective policies when you can do them. So means matter. And we know that there are national trends and differences depending on the access to different methods. Accessibility is a huge issue. But means restrictions are also limited by ecological factors. I defy you to have a country without rope, or I defy you to have Hong Kong without high buildings. And sadly enough, I defy the United States to have its world without lots of firearms. So there are limiting factors that we will always have to acknowledge. Challenge 3 is we got a whole bunch of talented people. Think of all the talented people in this room. Think of all the abilities that we have if we could only reach the person who's suicidal. So there is a mismatch between what we could do and where they are. And this is really a failure of the clinical system. It's a failure of our thinking. Now, the good thing about selective and indicated interventions is they reach into communities to find and engage those who require treatment. And that's very important. Looks like I have 2 1s on that slide. 1 and 1. Okay, well, that's supposed to equal 2. Clinics wait for patients to come to their door. That's what a clinic is. That's what a doctor's office, a therapist's office. When you go out into communities, you are doing public health work and you're trying to engage. But public health approaches must be most effective. They will be most effective when they are co-owned by all the members of the community and the public health community and the clinical community. If you don't have that shared responsibility, that shared ownership, the partnership, ultimately this will fail. Someone cannot be like, spraying a crop, from the sky, or the sprayers come over or whatever they do. Oh, it's all organic now. New Zealand has no sprayers anymore. Okay, well, still parts of the United States that planes spray, even though not in organic stuff. So you can actually do something which I call social geography and social ecology. You can map out a community. And you can go, I'm not going to go into all these things, but you could take a place, university. Who will I get if I work in the university? Well, I can find vulnerable students in university who are under great pressure, stress, problems drinking and that. Who do I miss? All the students who are not in university. So you can go through your entire society and ask, who do I capture and who do I miss in every place? You can actually make an inventory. And this becomes very valuable because then you can match that up against, well, what do we know about the burden of suicide? Where is it more and where is it less? Let's plot out a plan. And some of that plotting is geographic, and you can do this in all sorts of different settings. You can turn it around and say, well, I am really interested in some of these high-risk populations. So you take high-risk youth. Where are they? Where do they travel? How do they communicate? Who do they connect with? You can do this with psychiatric patients who elope from hospital or come in for an emergency visit and then disappear. Well, where do they go? And then you can track them all through the community. And between following their paths and also looking at the sample biases of each site, you can begin to say in a much more comprehensive way at a community level, how do we build a community strategy? If you say, I'm just interested in group A, then sure, you might be able to track group A and you might be able to find them, but that's not a suicide prevention program. That's a piece of something. So, mosaic, right? It's art creating images with an assemblage of small pieces of colored glass, stone, or materials. Some pieces are larger and some pieces are smaller. So, suicide prevention really is a mosaic, which is built both on geography and social ecology of populations. So for every piece of that glass, you should be asking yourself, if I build a really good effort for this single piece, how many lives will I account for? So in the United States, they've poured huge amounts of resources into youth suicide prevention. They have not had an effect on the national rate. There was no way that they could have had an effect on the national rate. There were not enough suicides among younger people where if they were going to, even my example of a 50% reduction is pretty startling. And yet it would not have matched the rise in suicide that was being carried by the middle years. So it's very important. I'm not saying don't do things for youth. It's very important to understand the impact of this mosaic. We don't know enough. We don't have enough theories. We don't have enough understanding about what are the true risk factors or what are the true protective factors. I mean, we are ignorant. And it's better to accept the sentence, which I use often, probably should be posted on my wall, I don't know. Of course, my kids, when they were adolescents, said, Dad, you think you know everything. No, I don't. I just don't want you to do this. You know, the difference between I don't want you to do and I know. Want wins out in that situation. Well, ultimately, they win out. They grow up. So here's some of the things I don't know. Here's the United States. Here are the tremendous variation of rates within the United States. Thought to be mostly the same culture. I don't know why it varies. Now, some people say it has to do with gun laws. Other people say it has to do with other things. I know I live in upstate New York where the rate is 7 per 100,000. Lots of guns around. Hunting is a culture that is deeply embedded in the society. You know, many, many people have long guns. So it isn't that. A second, I don't know. Here's something out of Hong Kong. I don't know if you can see. There's a line here. See if I can highlight it. Right there. And this line over there, right there, that's when charcoal burning became popular in Hong Kong, 1998. From 0 to 250 in a few years. From 0% of the suicides to 26% of the suicides. Using a hibachi and putting your face in the charcoal, breathing the carbon monoxide. Now, you wouldn't call that a cluster per se, you would call it a trend. A new method reaped a new harvest of death. In the UK, between the late 1800s and 1920 or 1930, domestic gas became common. The suicide rate among men tripled. Context is important. Clusters are simply, and I don't mean it in an understated way, simply another measure of context. Context affects suicide. We need to understand context. Not everybody will choose the same method. It is not true when someone says, well, if he doesn't have this method, he'll just use another. That actually turns out not to be supported by study again and again. But context matters. We don't understand that. This is from work by Paul Yip and me from Hong Kong. The unemployment rate goes up, the suicide rate goes up. The unemployment rate goes down, the suicide rate goes down. Turns out most of the deaths come from the employed, not the unemployed. The unemployed pool is too small relative to the employed pool to drive this. There were 150,000 people in the unemployed pool at the beginning of this. At its height, it was 250,000. It went back down to 150,000. The employed pool had 3 million. So a small increase in the employed pool from 7.5% to 12% accounted for much more suicides. Now, these people were under economic pressure, no doubt. But we always say, well, we got to look at the unemployed. Unemployment rate is an indicator of social distress, but we don't know how it really operates. And so again, we don't have theories for this. So we're starting to use a model that looks like this. So this is actually adapted from WHO. They had one on interpersonal violence, and I linked interpersonal violence and suicide. Again, you can get the slide. They'll post them somewhere. But the idea is that suicide doesn't occur outside a relationship, and it doesn't occur outside a community. They are embedded one in another. The suicide in a 15-year-old or a 17-year-old is not divorced from the parents. The suicide of a 35-year-old is not divorced from their children. You cannot do a suicide prevention program on youth that doesn't pay attention primarily to changing the environments in which the youth live, which are the parents. And so this is really critically important. Now, there are a lack of coordinated strategies. We don't have a good mosaic. We don't have a good plan where you ask how much does each of the pieces of the mosaic contribute to the overall whole. Now, this is true in the United States, and it's just come out with its second national strategy, and some of us had very powerful behind-the-scenes voices. It actually is moving in that direction. The first starter initiatives are probably more limited than some of us would like, but indeed, they've set up a recursive process, and now that we have a center funded by the Centers for Disease Control, as Luke mentioned, we're going to have a lot of input into this recursive discussion around and around and around and around. It's very important to have a suicide research enterprise which is enough politically attuned to inform the policy enterprise. If there's anything you can do, it's to create that kind of enterprise in an ongoing way so there's a back and forth discussion. Somebody has to be the truth teller about the facts, someone else has to be the truth teller about what's doable in policy. Now, the US Air Force actually had a program that brought down suicide and brought it down for a sustained period. But it turned out it wasn't just a suicide prevention program, it was a violence prevention program. Homicide, accidental death came down as well. I just want to point out, it went back up again starkly in 2004. I know I'm going to have to stop. And he's telling me to shut up. He did it so gently. It went back up in 2004 because they stopped doing the program. You know, a war was going on. They reinitiated the program and went back down. It's gone back up again, but that's not published yet. So this is the picture I would like to have as a takeaway picture, this one and the next one, and then I'll stop. Which is, I really view suicide as one of several mountaintops, depending on the age group. This is premature death among youth. You have to lower all of the mountain peaks. The only way to do it is to lower the base. The base has to do with socioeconomic conditions and family factors, schooling, abuse, alcohol, all the kinds of things that many groups separately think are important, but these groups rarely unite to a common cause, or what I call a common risk. And so this is the way I think in the future we will succeed. There's tremendous amount of goodwill to do these things. In an 18-year-old, there's not much difference between death from a motor vehicle accident, death from a drug overdose, or death from suicide. They have common roots. In a 40-year-old, there's not much difference between alcoholic cirrhosis and death from suicide. They have common roots. Now, it's also important to remember that something like counseling and education that depends on changing an individual, capturing them, and helping them to change is probably the least effective public health strategy. You know, means control. Speed bumps. You know, speed bumps in motor vehicle settings can be very important to reduce speed in cars in front of schools, right? I defy you to go over some of those speed bumps and think your car will continue to run. So there are public health strategies that we can do. I'll skip the last slide and sort of say, you know, we've been trying to find a needle in a haystack. I don't think we can find the needle. I do think we can move the haystack.